All right, let's run through another case study. So this time we've got a patient with some patellofemoral stuff, IT band syndrome, high school volleyball player, going into her senior year, already committed to play Division I volleyball. So good athlete, having relatively acute pain over the last couple of weeks, really hasn't changed her activity level, really hasn't changed her training. Sounds like she does a good job with warm-up cool-down. So I've seen her previously, probably about a year or two ago, for something unrelated to this. And so she's coming in worried that she's got this problem going into her volleyball season because camp starts this week. I saw her for her initial evaluation last week. So comes in, says that she's been going to physical therapy somewhere else for like 2-3 weeks, not really seeing any improvement, and worried that this is going to become a long-term problem. So asked her what they were doing at previous physical therapy, and she said, well, he's trying to figure out which muscles aren't working and then get them to work. And I said, okay, so how is he figuring out what muscles aren't working? And she said, well, he has me do a squat and then says, okay, well, you're doing this when you're squatting, which means this muscle is not working. And we all know that's not how you assess individual muscle function. And that's not how you, especially with a good athlete, that is not how you assess what's going on here, because she's going to compensate faster than we can see what's going on. So told her, okay, well, that's not how that works. And the reason why you're not getting better is because he doesn't know how to assess what's going on. And I said, well, what is he doing for treatment after that? She said, well, he's trying to activate the muscles. And I said, how's he doing that? She said, well, I think he's using a laser. So not sure how that works, but once again, that's not how that works. So that's why she's not getting any better. So go through screen, she does pretty well. She's got pain with descending double leg squat. She's got pain with descending and ascending single leg squat. She's got pain on landing in a double leg hop, and she's got pain on landing and takeoff on a single leg hop. All her pain is kind of anterior lateral knee. So what does that tell us? That tells us we know that there are certain muscles that should be contracting or facilitated in those motions during those movement patterns, which probably aren't working. So I'm not going to take the eyeball test and say, well, you have pain when you do that. That means you have a weak VMO and you have tight hamstrings. So we're going to strengthen your VMO and then stretch your hamstrings. That's not how it works. So all I've done is seen what her gross motion is, what her report of what is going on is. Now I have to get more analytical and break her down muscle by muscle. So put her on the table, and what do you know? What muscles control pronation that she's having a problem with? Vastus lateralis, gluteus medius, soleus, some glute max, what else? A little bit of foot instability, so abductor hallucis. So go assess those. Those fail. So those are inhibited, which means they're failing contraction at the angle that they should be contracting. Now, does that mean that it's completely giving out and she can't do anything? No. What it means is when I test her, she stutters and she also says, that hurts my knee. So that's telling me that's what the problem is. So when I reverse the inhibition and I come back and I reassess it the second time and say, how's that? She's strong, it doesn't stutter, and she has no pain. So I just got rid of her pain in her anterior lateral knee by treating gluteus medius, which is far away from her knee. So how's that work? Okay. So remember, this is all based on physiology, biomechanics, anatomy. Okay. So go through, reverse that stuff, find some other things, pyramidalis, did some stuff on the other leg, get her up and redo the screen. So now, since I've got these things facilitated, she should be completely pain-free when she does the screen, right? Well, she's not. She still has pain, about 50% less pain, but she still has pain with all of the things that she had pain with before I treated her. So does that mean that we failed? No, that means that she is an elite athlete. She's a Division I commit, which means she compensates really, really, really well. So she's still using her compensatory patterns that she was using before I refacilitated. So Did I do anything that reestablishes or reinforces function on the table with manual therapy? No, none of that has anything to do with manual therapy or with function. I have to get her off the table and now have her do things to get those things to start kicking in. So when I have her do a body weight squat, she has knee pain in the exact same spot. When I hand her a 25-pound kettlebell and say, okay, now the body weight squat hurt, so I want you to do 10 kettlebell squats. And she looks at me like, well, if it hurt without weight, it's definitely gonna hurt with weight. So I said, trust me, do 10 squats. She does 10 squats. The first 2 are a little bit uncomfortable. The rest of the following 8 are pain-free, and she's getting ass to grass. So why is that happening? Because I'm forcing her to use what she hasn't been using for however long this has been going on. So remember, when you add weight, you're making the body use more muscle facilitation.